welcome everybody to CAHOTECH 2022. I hope you're enjoying yourself. And we have some outstanding speakers today. We have the first panel, which is going to be a series of talks. So for those who don't know me, I'm the Vice President of CAHO and also the Vice Chairman of Dr. Mehta's Hospitals. It's a privilege to hear a lot of the stories here and to understand what can make our healthcare life better tomorrow than it was yesterday. And I think technology is definitely one of the fundamental enablers. And if we can learn from a combination of our peers, our suppliers, and our customers, then life gets better. Today in India, we're also learning a lot from our government, because the project that they've taken on to kind of digitize the 1.3 billion people, which they've successfully done in payments, which they've successfully done in a number of other spaces, has really enabled a fundamental change. And I think we're about to see that in India. So the next 45 minutes, we're going to hear a lot about frugal innovation and how technology plays a key role in frugal innovation. I mean, you all survived COVID. Unlike most of the world, which had pretty limited populations, with the exception of China, which was highly opaque, India had this huge problem that kind of like landed on the government and the private providers, multiple of them across the country's doorsteps, on how do you solve for 1.3 billion people. No playbook in the world solves for that, because most of the developments globally have been done for fine-tuning very small populations or very specific populations with specific ailments, whereas we are a conglomerate of a number of different state health systems that are cobbled together with some central leadership. And I think that's the beauty of India, that we got to see sometimes the great things that happened in state A that were replicated in state B, and sometimes things that struggled in state A that got also replicated in state B, but with a learning curve that was there. And I think if we can figure out how to do this really well, we'll be the playbook, like we're already doing in many spaces, for the rest of the world. Already the payments platform, already the Aadhaar identification platform and the stack under it are in high demand from the rest of the world to understand. And I think that's the opportunity for all of us in healthcare. And I think there are no better speakers than the three that we have lined up for you. And we jump to Robert Dunlop, who is the clinical director at Elsevier. And if we could have Robert's profile put up a little bit. He's a general physician based out of New Zealand, a fellow of the Royal Australian College of Physicians, the fellow of the Royal Society of Medicine. He worked in technology, first with Aritso Technology with the Cancer Research UK, and then was acquired by Elsevier as an institution. They've developed some fantastic stuff in AI. In fact, the first successful implementation in Niti Aayog in India of AI has come through some of the work that Robert has been involved with. So I think with that, we'd love to hear a little bit more about the Health AI Catalyst project. And what are your views, Robert, in terms of this frugal method of serving 1.3 billion people?
Thank you very much for the introduction and for the opportunity to talk to the meeting today. It's been a 25-year road for me working on this type of AI technology. So during that time, I've been involved in 4 major national implementations. One in Australia for occupational health, one across New Zealand for family physicians, England for the public-facing health and symptom checker, and in Scotland, the telephone triage system. But for me, the most exciting has been the work that you mentioned, which we've done with Niti Aayog and the UK Department of International Trade. So what we did was to take the standard treatment guidelines published by the Government of India, including guidelines related, for example, to child and maternal health across infections, screening, anemia management, antenatal care, postnatal care. So about 20 guidelines in total. And we transformed those into what are called computer interpretable guidelines. which allowed frontline health workers, so these are the ASHAs and ANMs, within the aspirational district of Bahraj in Uttar Pradesh, to have intelligent history taking and personalized recommendations across multiple guidelines for each woman and each child that they visited. And we were able to follow that for a 4-month period. We collected data which demonstrated increased adherence to the standard treatment guidelines and so forth. The challenge, as you're rightly alluding to in the topic, is how do we then think about scaling that to the 1.3 billion population? And I wanted to just give some high-level thoughts and really leave it more open to the questions. There's clearly technical challenges, and one of the biggest technical challenges is the breadth of coverage within India. It's very extensive, but not complete. And so any technological innovation that's designed to deliver to frontline health workers or directly to patients needs to be offline as well as online. The second thing is that what we might consider to be innovation, which in our case is the very sophisticated way in which we can deliver these personal guidelines, actually to a frontline health worker, something that is innovative but quite disruptive to them is a simple date picker, which, you know, those of us that are familiar with going online and using a date picker to, you know, pick a date for a hotel appointment or an airline ticket, for an ASHA in rural India, it's a completely new phenomenon. There are many examples of the apps in use for example, in Gujarat, they have the wonderful Techo app, which is used, but the bulk of ASHAs and ANMs, particularly ASHAs, are not familiar with some of these technologies that we take for granted. When you're dealing with an innovation at the level of the clinicians that is so different, you have to use an evolutionary agile approach. We had to work very closely with the experts in AIMS and within Lady Hardinge Medical College, for example, to provide very clear examples of how the system would work, and then an iterative approach to deliver it into just one health district. But of course, across India as a whole, there's significant differences between not only states, but districts within states. And so any innovation has to take account of differences. For example, just a simple difference was that in the rural areas in Bahraj, the deworming treatments were recommended. But in Lucknow, the ASHAs and ANMs are not giving deworming because there's a difference in the view at the medical officer level about whether it should be used, for example, in pregnancy or not. So these are the kinds of things that we incorporate into the content in order to enable the various organizations that are responsible for both implementation and funding to have that sense of being able to put fingerprints on the system. There needs to be that sense that it's not one size fits all. The localization, therefore, as I say, is very important. But what we've also picked up is that when you're working with guideline content, and this is true not just of India, this is true globally, written guidelines are not intended to be used at the point of care. They are intended to be readable documents, and they follow a linear sequence, typically screening, risk assessment, diagnosis, treatment, whereas in practice, it's non-linear. So any system that ultimately aims to improve clinical outcomes, not just through detection of, say, diabetes, but the actual management of diabetes, has to account for that degree of variability in, well, another way I like to put it is that patients don't behave like algorithms. And so systems need to have that flexibility. A couple of other quick points. One is that in terms of integration, it's important to recognize that where a state like Gujarat has an existing system that is widely used by ASHAs and A&Ms, integration is crucial. Any solution needs to be on the back of, not instead of. And finally, with implementation, if you're looking at a national rollout of anything, it's important to recognize and understand the implementation processes that the government has built up, both at the federal level and at the state level. There are very, very good training capabilities with the National School of Training, for example, and also the way in which the states organize implementation of new programs across ASHAs and A&Ms. And any innovation that's seeking to roll out, the implementation aspect is huge, and you have to leverage existing systems. So those are just some thoughts based on experience and the work that we're currently doing.
And Robert, let me just take a leaf out of something Shravan had mentioned before you. Clearly in the world of GE, and they've got some fantastic machines, we've just been privileged to get a new one of their state-of-the-art cath lab. It's all about precision medicine. There's no compromise, high quality, and some of the functionality for clinicians is now outstanding. It makes life so much simpler for them. When you've been doing this, it sounds like a combination of data triage to a large extent, of getting this information from ASHAs, processing it quickly and giving it back in a useful format to the folks that need to do something. And as you said, localization with a high degree of training. As you rolled out these 4 different systems across 4 geographies, and I'm not sure the Brits and the Scots might agree or disagree whether they're part of different geographies, so we might push back on that, but population-wise, there are definitely different characteristics. Are we going a bit too much on the extreme of getting 100% solution when we roll these technologies out versus an 80-20? So with 20% of the effort, you capture 80% of the population, but it's good enough to give them superior health than they had yesterday, versus do you have to really look at the margins for the specialized protocol on specific diseases and therapeutics, especially for more remote folks, because you've managed New Zealand, Australia, and Scotland?
I think these are very, very important points. At the moment, guidelines that are published, for example, on the management of diabetes are really designed with the purpose of standardizing care. That's the fundamental concept underpinning them. Our approach is different. Our approach is that we're looking to personalize care. So precision medicine is very often linked to precise targeting, for example, of gene substitutions in a cancer. But actually in rural Barrage, if you're in a village and you're a woman who's just delivered, then one of the things we were able to do was to provide her with detailed information as choices, including the new contraception agents developed in India, only available in India, but not widely understood or known about by these women. So that personalization at that level is something which, as you rightly point out, is about the 80-20 approach. It's about saying, how can we overcome the fundamental problems that are affecting these villages across, so much of India at a level that maybe in the future we can get to these very precise, diagnostics, etc. But for a woman who's pregnant in rural India, it's really important that her anemia is controlled, because that's the most, what we saw was that was the most common high risk factor in their pregnancy. And only 20% of the guideline content is being followed in visits. So just getting to a point where we can get that level of personalization across multiple guidelines, because obviously just the one guideline on its own is not enough, I think is a big step forward. And it lays the foundation ultimately for enabling targeting, because we were seeing real-time information about every pregnant woman and every child that was being visited in that district. So you could see literally on a dashboard what was happening. And what was really exciting was that the professor of obstetrics and gynecology in Lady Harding, Professor Puri, she could monitor that, and she could specifically call an usher and say, I see that this particular woman has a specific issue. This is what you might want to think about. And that's the kind of sense of how you can target some of these interventions, perhaps in a context where you could be flooded otherwise.
No, and I think a lot of the clinical decision support systems we've seen from a clinician point of view or a practitioner point of view from Elsevier have been outstanding. And it's actually an area that makes life much simpler for the average clinician. But I think what you're doing now in India is almost like a step change, because you're actually enabling the next million folks to kind of like be part of that clinician support system to consumers that perhaps don't even have access. So I think outstanding. So I'm a bit conscious of time, and I think we're also still waiting for somebody. So actually, if you could follow that up. So I think, look, if there are any questions that we have for Shravan or Robert before we get Devi or Siddharth on, I think we're waiting for Siddharth to come on, and we'd love to hear more the pharma side. But when we look at clinical decision support, there's obviously we're working a lot in silos, and I think the opportunity for suppliers to work across each other to help healthcare systems is a very different thing now. I mean, you've obviously worked with the NHS, which is a standard unified system to a large extent. I think Australia has a pretty standard unified, well, sort of at times. I'm sure New Zealand has. But when you look at India, we are nowhere near having a standard unified system. And I think, is that something that you think the middleware opportunity in India and perhaps the world is actually a much more important near-term target than perhaps trying for some of these moonshots? And that's also deep, Shravan.
Yeah, well, I think that actually India offers a major opportunity here, because what has happened in the last 20 years with the increasing government investment in the grassroots delivery processes now sees ARSHs and A&Ms distributed across the whole country. At the PHC level, it's a bit more difficult because, as you know, the shortage of physicians is acutely felt in these environments. But you have these workforces, which I have to say, from the visits I've made to multiple villages and towns and seen the camps they run, it's an unprecedented, and it's certainly, there's nothing like it in the UK at that level. It's an opportunity, because it's supported by, you know, all of these training processes, these implementation processes. It's actually a very robust system. And I'm excited by it, because if you're going to try and deliver something at scale at this level of the whole country, who knows how long that would take, but you have to have vision. You have to have something that will drive you, because it's a long road. It's a tough road. It's not a simple thing. And for me, seeing what is possible in this specific context, I'm not talking about, you know, the use of these sophisticated devices, etc., because that's a different ballgame. But for the delivery of the basics into these villages, it's very powerful. And for me, it's the vision that keeps us going.
It's great. Thanks, Robert. I think with that, let me sum up. Thank the wonderful panelists on a digital weekend. It's been a privilege and a pleasure to have your wisdom and thoughts shared on our panel.